This morning's discussion on Seinfeld's episode, I think it's the non-fat yogurt. All right, where would the group like to start?
I think we see that George is kind of just like a pathological liar throughout the entire episode. He just keeps on adding more and more lies, and even takes it as far as like getting a whole doctor's appointment, all that, just to prove that he's right, I guess.
And without getting into specifics and without getting into any medical jargon or diagnoses, any parallel? I know that the parallel is going to be narrow here because George actually does present to a physician. What parallel do we see? What scenarios do we see in clinical medicine that is metaphorically acted out in his subplot?
People that want to get drugs, maybe?
It could be. I mean, generally speaking, and there's different acronyms here, but basically people presenting with medically unexplained physical symptoms.
Yeah.
Sometimes it's called MUPS, probably an outdated word. But there are situations in which individuals will present to a clinician, to a physician, with what is often referred to as a chief complaint or chief concern, and that chief complaint is not supported by the physical or objective evidence. Physical examination, laboratory results, other diagnostic workup. And we'll get through this, and I don't want to really, maybe after we stop our live stream, if you remind me, we'll actually do a bit of an academic exercise, but I think for purposes of this discussion and our focus on George Costanza in the non-fat yogurt, our formulation, our decision tree, at this point is either going to be in one direction or another, right? So we're going to take a fork in the road. Either George is making a conscious effort to deceive us or he is not. If there's no evidence that our patient is consciously trying to provide misinformation, the default is always that they're not, right? So there must be evidence to suggest that our patients are actually deceiving us. In the absence of such evidence, we're going to say that it's not there. The burden of proof's on us, basically, as clinicians. If, as in this case, it is revealed that George is lying, because even before he goes to the physician's office, we see what happens in that ice cream parlor, in that shop. So we know that he's lying, right? So there is evidence there, albeit in the scene prior. When that happens, we have a two-part differential diagnosis when it comes to medical terminology, when it comes to diagnosis. What are the two conditions now that as clinicians we have to consider for George Costanza? When a person presents with medically unexplained physical symptoms for which there is no underlying established physical cause, and the patient is caught in a lie. They are deceiving.
Delusions? No.
Nope. One is called malingering. That's really an older term. The American Psychiatric Association is phasing that term out, but it could appear in shelf exams.
It does.
Grace said Munchausen syndrome?
I'm going to give you Munchausen's. That is the older term for what is now referred to as factitious disorder. Somebody got in the chat, good. And while factitious will almost, I can't say definitely, but likely be on a shelf exam, Munchausen's probably not. That's very outdated. What differentiates the condition formerly known as malingering from factitious disorder?
In malingering, they're doing it for some type of specific gain. In factitious disorder, they're doing it for like the benefit of the sick role.
Yeah. And when you say specific gain, we'll actually use a little bit of different terminology: external gain or reward, right? Reward, gain, motivation, rather interchangeable terms. So very similar. You have to ask yourself the question as a clinician: is there any evidence of an external reward, like drugs, right? Like workman's compensation? If the answer is no, then it doesn't exist. The burden of proof is on us. Right? So it is always in this particular part of the decision tree, it is always factitious disorder until proven otherwise. Right?
Makes sense.
On the other hand, let's say that the individual was never caught in that lie. They were never caught in their deceit. This also provides us, albeit in a different direction, a two-part differential diagnosis. What are the two conditions published in the DSM? For an individual who comes in with medically unexplained physical symptoms, and there's no evidence that they're deceiving us or trying to deceive us.
Conversion disorder or somatic symptom disorder?
Everybody go ahead. Sorry. Somatic symptom disorder is the larger condition in which an individual, get ready for this because this is the rocket science of psychiatry, presents with physical symptoms for which no underlying physical cause can be found. Right, so pretty straightforward. When that chief complaint, when that chief concern involves voluntary, motor, or sensory function, is that somatic symptom disorder? It actually is, but it's common enough where we've pulled it out of the general classification and created its own name. We gave it its own label, and that's called conversion disorder. So acute blindness, paralysis, weakness. It's that subtype of somatic symptom disorder called conversion disorder. George Costanza appears to be malingering. Right? He's lying, and at least in the script, there is an external incentive as to why he's lying. Questions about the 2x2 differential diagnosis for medically unexplained physical symptoms? Anything else with regard to George Costanza? What other characters?
Do you think maybe because it seemed towards the end of the episode that he actually was feeling the symptoms when he hit his head or hit his arm on the desk. Do you think it could have been a placebo effect maybe that
Factitious. Yeah.
Yeah, because he's I've been acting it, but now it's oh my god, it's actually happening, but maybe it's
yeah, and I think what Larry David does is as a plot twist, he actually ends up with the very symptom, but now he is not making a conscious effort to deceive. So, and if that is true, we're going to call it either somatic symptom disorder or, to the extent that it involves motor activity, probably conversion disorder. So maybe at the end of this particular episode, at the end of the non-fat yogurt, George Costanza actually does demonstrate signs consistent with conversion disorder. Which actually brings up one more clinical pearl. I don't think this will appear on a shelf exam. But as a clinical pearl, we teach these really 4 sets of illnesses here. This 2x2 differential. And if you think about it in a 2x2 rubric, you could have 4 quadrants. The lines that divide this into 4 squares are dotted. They're not solid, right? So even though we would think that motivation or gain separates factitious from malingering, that's a gray area. What's motivating a person? What's motivating human behavior? Sometimes it's not quite clear clinically whether it's one or the other. And maybe the last couple of minutes of this particular episode demonstrate that all of a sudden he's doing it, and it seems like it's coming from another motivation or gain. And maybe this is actually a conversion reaction now. Can you do that? Can you have the exact same symptom where minutes prior it was malingering and now it's a conversion reaction? And the answer is yes. So those lines are dotted. They're not solid. More of a clinical pearl. What are the characters? The non-fat yogurt would the group like to discuss this morning? The answer cannot possibly be no.
I think it was hard for me to watch it from a Dr. Tobio's lens because I just thought it was
I would advise strongly against that.
I just found it so funny. I don't know, I just thought it was so funny.
Mm-hmm.
In the beginning, I was just looking at it from a psych lens, but then now I'm just watching whatever the movie.
Yeah, I would strongly encourage you guys to enjoy the situational comedy for its true value, which is one of the top comedies ever made. So
yeah,
keep it fun for you guys. Bringing it to the psychiatric teaching points is on me. Yeah, even for medical students in the room. What else scene character caught your eye? Funny, laugh out loud.
the child because he was cursing, right? And the mother was blaming it on the comedian, but then she was cursing too in front of the child, and I was just like, oh, okay, well, she's not seeing, that she's doing it.
Yeah. Yeah, again, I think with a full disclaimer that I'm not a child or adolescent psychiatrist, we could talk a little bit about human development here, and then modeling. Along these lines, children in general from, I want to say 2, but it's probably even younger, sponges. And they do not have developed cortices yet. They do not have a developed cerebral cortex, and that means they do not have a developed superego. Children say the darndest things, and very similar to, and there's a parallel here when it comes to geriatric psychiatry as well. But there is often a no filter in place with regard to what they're thinking, and therefore the impulses that will be allowed to come to conscious awareness and even acted upon. And that's what we see here. That child probably doesn't know that F-bomb is as bad as it is. Right? It's just honest and innocent. Right? So I know I didn't sign Benjamin Buttons, but there's a loop, there's a U-shaped curve in which we grow out of that. We have a developed cortex, and that superego then develops, and we know what to say, what not to say, and when to either say or avoid saying things. We lose that capacity later on, and it's often difficult because I think our culture allows us to understand that someone who is 4 or 5 or 6 can get away with that. Children are innocent. Then you leave that innocence, right? You actually shed that innocence and that egocentrism, and you have to act more and more like an adult. And then you could apply any stage theory here, whether it's Freud, whether it's Erikson, etc. At some point, you then regress back to that childhood state. But for our culture, you don't look the same, right? You're older now. So our elderly are not given the benefit of being innocent, right? Because they've actually transitioned through a stage where they weren't innocent. They were adults. But the regression, especially for the cortex, and therefore especially for the id expression, that id impulse, is that of a child. An individual struggling with conditions like major neurocognitive disorder, aka dementia, will be as impulsive as. They will strike co-workers in residential healthcare facilities, nursing homes, just the way a kid might strike, a 2 or 3-year-old might strike their friend. So we see this, it's very similar behavior, and it's very similar neurobiologically. And it really does focus, and it really does allow us to discuss aspects of geriatric medicine and geriatric psychiatry. Now, it would be interesting if somebody like Uncle Leo were in this episode, who actually does, of all things, malinger and lie that he has, of all things, dementia. Probably should have went back to back with those episodes. But having somebody like Uncle Leo in this episode juxtapositioned with that child would have been an interesting discussion, because it would illustrate exactly what we're referring to here. Said a couple things. I want to make sure we actually have the DSM definitions for here. There are 2 conditions when it comes to neurocognitive disorders that I think we should briefly touch on. One I mentioned, major neurocognitive disorder. The other one's mild, right? Anybody care to guess the difference between major and mild neurocognitive disorder?
Major's worse.
It is worse. It is worse. I can't ding you for that. It is worse, and it is worse because individuals with what was formerly known as dementia demonstrate subclinical significance, right? Clinically significant distress or impairment in functioning. When an individual has cognitive deficits that are without that clinical significance, we call it mild neurocognitive disorder. And it's interesting because it's one of the rare cases, per the American Psychiatric Association, where we use the word disorder, and the condition is defined literally as not having any clinical impact. Right? It's a little bit of an odd, almost a misnomer. It's mild and it's not a disorder, but they call it mild neurocognitive disorder. There are other conditions in the DSM with a similar definition, with a similar hallmark of not being clinically significant. Right? I think the golden rule is that anytime you hear the D word, there's clinical significance, clinically significant distress or impairment in functioning. Other than mild neurocognitive disorder, that misnomer, what are the other conditions published in the DSM that are literally defined as not being clinically significant? There's two others we probably should discuss.
ADHD?
Nope. One is called mild depressive disorder or mild depression, which of course differentiates from major depressive disorder. And the other one is hypomania, which differentiates from mania. If you look at these respective conditions, whether it's the depressive disorder or the bipolar disorder, the signs and the symptoms are very, very similar, if not exactly the same. In the case of a manic episode, we often remember the signs and symptoms, the diagnostic criteria through the acronym DIGFAST. Well, DIGFAST defines mania and DIGFAST defines hypomania. The difference is that hypomania, by definition, is not clinically significant, while mania is. There's also a timeline, too. And someone who has hypomania has to have both conditions. That is, it must be less than 7 days and must not impact functioning. Fortunately, the APA didn't name it hypomanic disorder because that would have been their second misnomer. They actually got that one right. We could talk about this later, especially in as much as it might apply on rounds. But these other conditions of mild depression or minor depression and hypomania help with further definitions within the bipolar and related disorder, specifically bipolar 2 and cyclothymic disorder. I think it's a little bit beyond the scope of this morning's discussion, but we'll work it into rounds. Before we end, what other observations do we have with regard to the non-fat yogurt? Any other characters or scenes you'd like to discuss?
I think Kramer shows like ADHD quite a bit between just like his like constantly there's like bursts of energy, and then like you just see throughout like almost every scene he's like switching from task to task like pretty rapidly, and he gets like hyper fixated on like one thing, like trying to prove that the yogurt was like non-fat. So.
Yeah, there's a couple of elements here. One is the content of his focus, which does trend to the bizarre. Right? I mean, he undertakes tasks, the content of which not a lot of people would invest a considerable amount of time thinking about, much less doing. And then the other is the process, the way he goes about doing it, which is somewhat impulsive, like you had mentioned, appears to have an element of hyperactivity, as well as attention deficit. Keeping consistent with the definition, we do see this in multiple domains. It isn't like he just acts that way when he's in Jerry's apartment. It's pervasive. And now, usually we have objective scales like the Connor scale to actually come up with a score in different domains, school, home, etc. With some irony, Kramer really doesn't work, so we really can't focus.
Not really.
No, and there's episodes where he does work, and it becomes its own subplot because he hasn't worked basically his adult life. We learn that he's been on strike for the entire 9 seasons.
For what?
He worked in a bagel place, a bagel shop.
He invested in the yogurt shop, right?
He invested in the
Oh.
Yeah.
And he made a boom.
Yeah. Yeah, I don't know where. Even Jerry's commented on more than one occasion. We don't know where he gets his money.
How he survived.
Yeah. Well, I think we never see his refrigerator, not even from the exterior. So, but we do see him eat very frequently out of Jerry's kitchen.
Yeah,
So,
I guess so.
that's Kramer.
There's a question on
Yeah.
Zoom from Greece. It says if they don't present with clinical significance, how do we find out they have a neurocognitive disorder?
Yeah, usually the family. It's usually the daughter. Yeah. It's usually the children who have concern. Dad's forgetting his keys more often. It's something that the family usually picks up on. And whether or not they actually get a full neuropsych battery is, I think, up to the institution, up to the clinician. But the definition or the diagnosis of either major or mild is a clinical diagnosis, and you can make that through a psych assessment. But I mean, my bias would be a psych assessment from a geriatric psychiatrist, if not a geriatric neurologist. All right, we'll leave it there. We have a brief break, about 10 minutes, before we log on our Zoom and have our next didactic. We'll see you on that end.